Hello, I'm Dr. Omar Bey. Welcome to Physicians Health Network. We're a group of Black physicians that are here to answer your medical questions. Our focus is health, education, and wellness. We're here to answer medical questions from a Black physician's perspective. No big words, that's our goal. We want to break it down so that each and every one of you understand exactly what we're talking about so that you can understand your medical problems. So the first thing I'd like to do in introducing our show is to introduce the physicians who are here today. All righty. I'm going to introduce as I see them on my screen. So please, it may be out of order for you, but we will go forward. Dr. Court, can you please introduce yourself?
Good afternoon. My name is Dr. James Court, Howard University, class of 1980. Proud to be a Bison. I practice internal medicine in East Orange, New Jersey.
Righty. Thank you, Dr. Court. Dr. Devasti. Dr. Devasti is our guest physician this month, and we're so happy to have him. He's a holistic as well as a natural medicine physician. Dr. Devasti, introduce yourself.
I am Dr. Gerard Devasti. I'm an internist, and I have a board certification in integrative and holistic medicine. I've been practicing natural medicine for the past 30 years.
Excellent. We look forward to asking and getting answers from you, asking the questions and getting answers. Dr. Atherley, Trevor Atherley.
Hi, my name is Trevor Atherley. Good afternoon, everyone. Always a pleasure to be with you. Essentially, I'm an interventional cardiologist, board certified cardiologist. And in addition to my practice, I enjoy playing a role as a teaching the interns, residents, medical students, and or cardiology fellows in training at Newark, Beth Israel. I'm located in Newark, Essex County, New Jersey.
All righty, thank you. Dr. James Lee.
Good afternoon, Dr. James Lee Jr. I'm a second generation board certified orthopedic surgeon practicing in Essex County. I'm on faculty, Department of Orthopedic Surgery at Rutgers University.
All righty. And Dr. Kevin Clark, your mic is on, Kevin. Off. Thank you. Turn your mic on.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel with all these distinguished gentlemen here.
All right, thank you. And Dr. Dwayne Fredericks.
I'm Dr. Dwayne Fredericks. I went to Lincoln University, class of 87, the original HBCU. I'm a bariatric surgeon, and I actually practice medical management for weight issues. I'm in South Orange, New Jersey.
Excellent, excellent. Dr. Kendall Sprout.
Yes, I'm Morehouse College, the best of the bunch, class of 73. The new Senator Warnock is also from Morehouse, as was Dr. Martin Luther King. But anyway, I'm a pediatrician, board certified pediatrician. I'm doing mostly administrative work at this point. Gerard was a student at one point under me.
I remember you very well.
And I did general pediatrics as well as critical care pediatrics. So thank you for having me.
All righty. And Dr. Nelson Aluya. Dr. Aluya, can you hear me? All righty, we're having a little audio problem with Dr. Aluya.
Can you guys hear me?
Yes, we can. Yeah. Introduce yourself.
Oh, okay. Well, I don't know what's wrong with my phone here. But I was on with the introduction. My name is Nelson Aluya. I'm ABU, Ahmadu University trained in Nigeria, Zaria. Assistant professor of medicine at the Rutgers University Medical School. Also an attending physician at the Newark Beth Israel Medical Center here in Newark, New Jersey. It's a great honor to be here this afternoon in your presence and the presence of this amazing, great and highly extinguished and amazing doctors. Thank you.
All righty. And I'm Dr. Omar Bey. I'm a pulmonary critical care physician with a specialty in nutrition. I've been practicing for too many years, I think. I won't say how many, but I'm so grateful to be here with all of these distinguished physicians. All righty, let's get going. I just want to lay some ground rules. Number one is that we are the Physicians Health Network, and we will be broadcasting this webinar the second Saturday of every month at 1 o'clock. And please tell family and friends. It takes a village, so we want everyone to come and hear what we have to say. So we would love to answer your medical questions. If you missed the webinar, we are on YouTube, and you can go to OBHealthy on YouTube and definitely subscribe so that we can continue to offer these webinars on YouTube. The most important thing I have to say is please do not change any aspect of your medical care until you can consult your physician. We're here as educational physicians. We want you to be as educated as possible about your medical conditions, but we don't want you to change anything from no matter what we say. Your physician is the one that knows you best. That's the one that should guide your medical care. I also would like to thank OBHealthy for allowing us to use their platform to bring this webinar to you. OBHealthy is a weight loss company, and you can check them out. They're on, they have an app, and you can check that out, or you can check out their website and see what they're all about. Okay, let's get going. The first question, and since Dr. Devasti is our guest, we are definitely going to come and talk about holistic medicine a lot, but let's get started. And there's some questions that are coming up here, and there's one on diabetes, and it states that why is diabetes one of the major reasons that you can lose your kidneys? Now, I know diabetes is that type of disease that it affects so many organs of the body, all right? But it does affect the kidneys. Can one of the doctors, either Dr. Court or Dr. Aluya, can we start off with diabetes and just talk about some of answer the question number one, but talk about diabetes a little bit? Dr. Aluya?
All right, well, it's a pleasure, thank you. Well, diabetes, as we all know, was actually made as considered an epidemic in 2016 by the WHO and of course CDC, because it has become so prevalent and affects almost everyone, every race, irrespective of your tribe, creed, or ethnic background. It affects kids as well as it affects adults. For those that, then it became classified into, type 1. This is usually the one that affects younger kids or children, where your pancreas, which is the organ that produces your insulin, gets completely shut down. It gets shut down for a number of reasons, either genetics or from infection, from viruses, most likely. Usually happens at the beginning of fall. And then you have the type 2, which is the type where your immune system, for some reason, affects your body changes and affects the way the function of the insulin as the pancreas produces the insulin. So your pancreas still produces the insulin, but then it doesn't get into the tissue, because for the insulin that your body produces to get into your tissue so that you can utilize the glucose or the sugar that you eat, it must get into the tissue, and that's where insulin comes in. But for some reason, over time, progressively, there's what they call insulin resistance, meaning there's a resistance between the insulin getting into your tissue. A number of reasons can affect that. Increase in body weight, diseases, connective tissue disease like lupus, osteoarthritis, rheumatoid arthritis, or every other kind of disease that can happen, chronic medical issues, or just genetics by itself, or by the food that you eat. And that's where the entity came up, where we start talking about pre-diabetes, meaning there are individuals who have a risk of becoming diabetic, but they're not diabetic yet. So usually we have an insulin, what they call the A1C. A1C is the measure of what your sugar has been within the last 3 months. They do that because glucose is attached to your red blood cell, which is the oxygen carrying cell. And each one lasts for about 3 months. So 190 days, 20 days. So once we measure the amount of glucose in that cell before it dies, it gives you a picture of what your sugar has been for the last 3 months. So for those who are at risk, usually if you have 5.7 or less, you're not considered as diabetic, but 5.7 to 6.5, without symptoms, you're considered as pre-diabetic. And then on of 7 with symptoms, you're considered as being diabetic.
Right.
So in this country, let me give a shot to, in this country, we have over 34 million people who have diabetes right now, and 88 million people who are pre-diabetic. So if you're pre-diabetic, it means within the next 4 years, you may become diabetic.
Right, right. Thank you, thank you. That was good. And the thing of it is that the question really geared towards losing your kidneys. I know diabetes is one of the those diseases that definitely, as an endpoint, there is kidney disease. Can we explain why the kidneys are lost? Is it that the nerves go into the kidneys are disturbed, or is it the blood vessels, or is it Dr. Sprock? Can you help us out with some of that?
Yeah, I think that most people that have diabetes, and it doesn't matter whether or not it's type 2, which is where you make lots of insulin, but it doesn't work so well, or type 1, where you don't make insulin. But what tends to happen is that diabetes affects the small blood vessels.
Right.
And so when you talk about some people that have diabetes, they have diabetic neuropathy. That means that they have pain associated with diabetes. And that's because it affects the tiny blood vessels that supply oxygen to the nerves. And so the kidney is responsible for regulating lots of different things. And one of the presenting symptoms of diabetes may be increased urination, because the kidney has the ability to reabsorb a lot of the things that are filtered by the blood, one of which is glucose. And in general, it's able to reabsorb all of the glucose that's filtered. But once the glucose levels in the blood reaches a certain point, usually about 180, it's no longer able to reabsorb the glucose that's being filtered. That glucose then gets spilled into the urine and carries water with it. And so one of the hallmarks of diabetes is increased frequency of urination, associated with weight loss as well, because insulin, which Dr. Luya spoke about, is a hormone made by the pancreas. It's responsible for facilitating the entry of glucose into cells. It also pushes potassium, which is one of the chemicals that is primarily within cells. It also prevents the breakdown of fat. And one of the things that happens if you don't make insulin is that you tend to break down fats, and you can have an increased amount of acid in your blood. In those individuals that have type 2 diabetes, they usually have lots of insulin, and therefore, even though it doesn't promote the entry of glucose into the cells as well, it does prevent the breakdown of fat. So they usually don't have any acid buildup. But the damage to small vessels, including the blood vessels in the extremities, where individuals may have loss of digits or loss of amputations of certain things because of damage to the blood vessels there, also can damage small blood vessels in the eye, and so it can lead to blindness. So the neuropathy, the kidneys, the extremities, any kind of small blood vessel that you can think about is damaged by diabetes long term. And if you can control your blood sugar by taking the medications or using dietary measures, and Dr. DeVaste may talk about some of the dietary measures, you might not have some of the problems related to that. But in this country, when Dr. Luya talked about the number of people that have diabetes is the leading cause of kidney failure. And the reason that so many people are on dialysis and may need to ultimately have a kidney transplant. But you can see, especially in Black communities, the number of dialysis sites are booming. And the major reason for that is because of the complications of kidney damage secondary to diabetes. It's the leading cause of kidney failure in the country.
Right.
Omar,
Oh, yes, yes. Go ahead, Dr. Court.
I may just add that the problem with the kidneys is because of the effect on the small vessels, it causes damage to the tubules.
Mm-hmm.
And if a certain number of tubules are damaged, then you can have kidney failure.
Mm-hmm. Yeah. Mm-hmm. Yeah, yeah.
Dr. Bay, can I add something too?
You sure may.
Yeah, so in the orthopedic world, increased blood glucose diabetes can affect wound healing, and it can affect fracture healing. We see a lot of diabetic ankle fractures, and many of these folks are at risk for losing that extremity because the bone doesn't heal. They don't feel the pain, so they're walking on a broken bone, and it ends up with a bad deformity, ends up with ulcers, and then bacteria love that environment of having a lot of sugar. And so oftentimes, it's a very delicate situation when we're treating patients with diabetes, especially if it's uncontrolled. In more of an elective setting, when we're looking at somebody for total joint replacement candidacy, say, can we have this joint replacement? If their hemoglobin A1C is 7 or above, oftentimes we'll say, well, you have to go back to your doctor and get that under control because the wound may not heal and they're at risk for complications. So it's something that we see quite frequently.
Oh, excellent.
What I'd like to add is that diabetes is extremely important, not only because of the focal or limited areas that you mentioned, but because it is so diverse, so diffuse in terms of its involvement with the entire body. And from my viewpoint, diabetes has been associated with heart disease in many, many different ways. What we like to look at are the factors that give rise to or potentially can cause heart attacks. And diabetes is one of the worst. In fact, it may be the most significant of the risk factors that we have that can predispose one to blocked arteries in the heart, and these blocked arteries could give rise to heart attacks. Furthermore, one of the concerns about diabetes and heart attacks is that unlike the typical heart attack, where chest pain is paramount, chest pain is the leading indicator of a problem occurring, that diabetes is notorious for having what are called silent myocardial infarctions or silent heart attacks, where the symptoms that the patient may feel or experience are may not be the same as others. And one may have some vague symptoms which require a lot more diagnostics to be able to pick up that one is indeed having a heart attack. So diabetes is really a truly very significant overall bodily impairment.
Right.
Omar,
I'd like
if I might
to
say
say
something real quick,
if it's
I
possible.
apologize, I joined late.
Yeah, Dr. Anderson, I'm going to introduce you in a minute. Can you hold your question?
It was a comment. Okay.
For a second. Dr. DeBasti is going to talk, and then I'll come right back to you.
Okay. One of the things that we see all the time in diabetics is that they have chronic inflammation. Chronic inflammation now is in every gravy. No matter what you have inflammation. We get older in part because of chronic inflammation. We get cancer is chronic inflammation is involved. The same thing for high blood pressure. If you control somebody's blood pressure very well, it will not prevent that patient to have increased risk of a stroke or a heart attack, even though the pressure will be completely controlled compared to people who do not have the same blood pressure. If you have somebody with blood pressure and you control the blood pressure is very well controlled compared to a group of people who do not have high blood pressure, but who have a comparable high blood pressure. The patients who have high blood pressure will have increased risk, even if the blood pressure is strictly controlled. And the reason is because you have increased oxidation stress in this. And the same thing with diabetes. One of the things I do with diabetic patients, I put them on few natural medicine to keep the integrity of the wall of their blood vessels. One of them is a grapeseed extract, excellent for diabetic retinopathy, excellent for people with ulcers and things in the lower extremities, excellent to prevent this. So we have to also take into account that chronic inflammation and chronic oxidative stress are very important in the course of the disease.
Excellent, excellent. Dr. Patrick Anderson joined us, and could you introduce yourself first, and then definitely we'd love to hear what you have to say.
Patrick Anderson, honored to be with the group as usual. I'm a GYN oncologist, chief of the Division of GYN Oncology at North Beth Israel Medical Center. Glad to be with you guys. My comment with respect to diabetes is in many of the hormonally driven cancers, as we know, diabetes is associated with obesity. And especially in the gynecologic world, one of the things we've thought is significant risk factor for uterine cancer is hypertension and obesity. And as we know, diabetes is associated with obesity. And with respect to the obesity, it's associated with a peripheral conversion of some of the male precursor hormones in the peripheral fat tissue to unopposed estrogen. And that puts many women at risk for uterine and to some extent breast cancer because of the additional hormonal conversion that has occurred, and it's unopposed. So again, we see when patients, especially in young patients who have what we call PCOS, polycystic ovarian syndrome, that's associated with insulin resistance. So that's whether they're quote unquote pre-diabetic or diabetic. These young patients, usually younger than the age of 40, are also at risk for developing uterine cancer.
Interesting, interesting. All righty. There's a couple questions that have come in. I'm gonna read the first one off here. Hold on. Oh, what can we do to bring down what can one do to bring down one's cholesterol level? Is a 192 cholesterol number too high? That's the first question. Dr. Atherley, can you start off, help us out with that? And maybe some of the internal medicine people as well?
Yeah, the level of cholesterol that we consider acceptable or appropriate nowadays has in fact been lowered compared to what was considered the average or appropriate cholesterol in the past. And we find that a lot of our management of cholesterol depends on the patient's underlying other illnesses. So that in fact, if you have multiple factors that can predispose you to heart disease, from my viewpoint, cholesterol being one of the more significant ones, that we may be a little bit more aggressive in terms of our control of the cholesterol number. If, for example, you've already had a previous heart attack, then to try to prevent or to diminish the occurrence of future heart attacks, we are a lot more demanding in terms of how low you bring that cholesterol. What we look at also is the characterization of the kind of cholesterol. And predominantly, we've looked grossly at two kinds of cholesterol, the LDL, or the bad cholesterol, and the HDL, high-density lipoproteins, which is considered the good cholesterol. The bad cholesterol, very simply, is the one that carries the cholesterol to deposit in the arteries to block them. We are concerned about cholesterol depositing and blocking arteries in a variety of places in the body. The good cholesterol transports away from and to allow the excretion of the cholesterol. So in essence, you not only want to have a low level of the bad cholesterol, but it is advantageous to have a high level of the good cholesterol. Now, the number 197 that was given may be referring to the total cholesterol.
Right.
It is the total cholesterol, again, depending upon the type of disease that you have. We prefer nowadays to break that down and look at the LDL and the HDL, as I mentioned, and give you some numbers for the LDL. Patients who've had severe heart disease, can you believe we're trying to get the LDL down to the level of 70 or less? If you've had previous myocardial infarctions, previous heart attacks, that's the kind of aggressive lowering that we want. Otherwise, 100 may be an arbitrary cutoff for your LDL. Between 100 and 130, I advise patients to rigidly follow dietary restrictions to try to lower it. Between 130 and 160, you may not be as successful. You can nonetheless give a quick trial of dietary control, but you may require medications. But when your cholesterol LDL is above 190, I don't think that you'll be successful in merely trying diet, and therefore we're obliged to very early start to give medications.
All right, that's it.
There's one thing that I would like to add that is usually not used in mainstream medicine. The LDL is broken down into a small, dense LDL and the large molecule. So if you're just looking at LDL itself, you need to get a breakdown of the LDL. Small, dense LDL increases the risk of cardiovascular disease. That's not so that much with large LDL. So when you do the LDL, you're not doing this everywhere, but this would be a great idea to take a look at what LDL that we are talking about. Is it the small, dense LDL or the large LDL, the bigger molecule? That would be a great idea to do. One more thing that sometimes people tell me that if you use fish oil, which I do a lot for many things, that it increases the LDL in patients. Yes, but it increases the large LDL, not the small dense LDL. So if you're just looking at the LDL alone, you will be missing the point.
Okay. What test, this is Dr. Court, what test should we order in order to determine the different LDLs? Because it doesn't come in a regular LabCorp or a Quest form.
It used to, but for some reason, the insurance companies are not paying for them anymore. So you can just request on the prescription pad, small dense LDL and large LDL, they'll give that to you. And so you will be able to know what kind of LDL you're talking about. This is really important because if you only go in by LDL, then you can miss the point of the difference between the size of the molecules of various LDLs. The same thing goes for HDL, but LDL is much more important.
Now,
Can I ask a quick question, if I may? Isn't it reasonable, though, that since we only have in our usual labs the total LDL or total HDL, that there is a correlation between the total LDL and the percentage of it, which is the bad portion, the small dense, as opposed to the other LDL, so that for the average, for most of our patients, we can still treat them appropriately based upon the usual LDL total, HDL total, etc. In some instances, it may be necessary to try to get a further breakdown of the LDL and of the HDL. But for most of the treatment of the vast majority of patients, would you say that just a simple gross measurement of the LDL and HDL would suffice for successful treatment?
Yes, I agree with that. But if you just want to get some more details from some patients, you can, to fine tune the treatment, you can measure the various size of the molecules.
But does this vary in patients, or is it standard that we can use for every patient in terms of the ratio between the small and the large LDL?
You could use that for every patient. This is available. You could use that for every patient.
Dr. Bay, could you talk about some of the foods that might help lower your cholesterol? Talked about restrictions, but there are some foods that you can take that also help lower your cholesterol.
Sorry, if I may add a little bit to that before you go on. If you, the next time anybody listening to, when you get your result, take a good look at it. It shows you I think about 4 or 5, parameters of your cholesterol. It gives you the total cholesterol. It gives you the LDL, which is considered the bad cholesterol. It gives you the HDL, which is the high density lipoprotein, which is the good cholesterol. It gives you a percentage of the cholesterol ratio, just like Dr. Atali said. It also gives you the very low density lipoprotein. And those ones are actually very important too. And then it gives you the triglycerides. Those are the parameters you tend to see when you see those results. So if a combination of all these things makes who you are or what your cholesterol really look like. Emphasis now, and I'm sure Dr. Atali will see that, I've seen very young men with no history of heart attacks in the family, no smoking, nothing else. The only thing that they've had, and I've seen about 5 or 6 of them, the only thing that they had when they came with a heart attack is a HDL of less than 25.
One of the comments I just want to just interject.
Go ahead, Dr. Doug.
As well,
Go ahead, Dr. Clark.
More non-medical questions is to try to use more non-medical
terms
to describe what we're talking about.
That's a very good.
Right.
And I agree, Dr. Clark. We gotta break it down just a little bit more for the general public, and that's true. That's true. We're getting a little technical here, and if it was only us, I'd love it, but we have to break it down just a little bit.
Dr. Bay, can I just a comment and a question for the panel? And I love to see Dr. Devasti. His was my mentor for a long time. We beat up on cholesterol, and we talk about cholesterol as though it's something that really we should be shy away from. But we need to bear in mind that the cholesterol is often the precursor to many intrinsic steroid hormones. And many of these hormones are necessary for the normal physiologic function of our cells. For example, the production of stress steroids, this production of sex steroids, all of which contribute to quality of life. So to put it all into
vitamin D.
if Dr. Devaste could comment on the whole cholesterol spectrum and its physiologic benefits.
If we don't have enough cholesterol, we cannot make the sex hormone. No testosterone, no estrogen, and specifically vitamin D. So if your cholesterol is too low, you cannot make vitamin D. And vitamin D, for the past few years, has been shown to be very low on almost everyone around the world, especially with dark-skinned people. The reason is because the synthesis of vitamin D starts in the skin by we don't want to use technical terms, but the light hits the skin and sets in motion a sequence of events that bring about the synthesis of vitamin D in other parts of the body. So if we don't have enough cholesterol to start, we will not make enough vitamin D. In addition to that, we are not exposed to the sun for enough period of time to stimulate the synthesis of vitamin D. So the end result is that most people do not have a normal level of vitamin D. The normal level of vitamin D is between 30 and 100 nanograms per milliliter. And according to that definition, if your vitamin D is 34, you are normal. But this is not acceptable because you have to have a level of vitamin D called the optimal level of vitamin D, which is at the level of vitamin D that allows you to enjoy all the benefits of vitamin D. You're not there until you are 50, 60. For about COVID, we know now, it's been talked so many times, that patients who have low levels of vitamin D have a much higher mortality than patients who have a high level of vitamin D. So all patients who have COVID, I put them on very high level of vitamin D for 3 days, 50,000 international units of vitamin D a day for 3 days. To fast quickly brings the level of vitamin D way up. The reason is vitamin D helps synthesize antimicrobial peptides, which are involved in the immune system, the activity of the immune system. So if you don't have enough vitamin D, you will not be able to deal with COVID well because you have a depressed immune system as a result of a low level of vitamin D, at least not the optimal level of vitamin D.
Dr. Devaste, let me chime in on that. What level of vitamin D do you give someone who is not per se low, but they want to maintain their level? What is a daily regimen?
I measure the level of vitamin D. You measure 25 hydroxyvitamin D, not 125, but you measure 25 hydroxyvitamin D to see what the level of vitamin D is. If that patient doesn't have optimal level, which is 50, 60, then I'm going to put them on 5,000 international units a day, vitamin D3, not D2. D2 is synthetic vitamin. I give vitamin D3, cholecalciferol. So now that will, within 3 months, you saturate your system. There is a problem with Black women who resist. You can give them vitamin D, and you measure vitamin D in 3 months, and the vitamin D increased by 5. The vitamin was 25, and now it's 30. So that's not acceptable. So these patients, I will give you 10,000 international units a day and measure it in 3 months. And usually it works. And some, except for COVID patient, I put them on 50,000 a day for 3 days to bring the level and allow them to boost their immune system to deal with the viral infection.
So let me again, create a little bit of controversy. So when we treat patients for hypercholesterolemia, are you suggesting that we should now adjust our vitamin D recommendation for some of those patients?
No. For high cholesterol, I use first try diet. If you reduce your carbohydrate consumption, you will reduce the stimulation of insulin production and your weight will go down, and that in turn will cause you to lose or to drop your cholesterol. In addition, there are other things in natural stuff that you can give. Cinnamon. Cinnamon is an excellent natural treatment for cholesterol. So it will drop your cholesterol. I tend to stay away from the statins because the statins are known to have severe side effects. muscular toxicity, liver toxicity, and also general amnesia. So this is important to know that you don't quickly. Now, sometimes you have to. If I have to, then I will put them coenzyme Q10 because the statins are known to inhibit the synthesis of coenzyme Q10 in the human body, which is so important. And this is why they have those side effects. This is why they have liver toxicity. This is why they have muscular toxicity. This is why they have the general amnesia. So nobody should be on statins or some other stuff if they don't put them on coenzyme Q10 to prevent that problem that it will cause.
Okay, excellent, excellent. All righty, there are quite a few questions that are coming up here, and let me look at a few. There's one that came in from, and it states, do you know if the COVID vaccine changes your DNA? Now, we understand that the COVID vaccine is and that the COVID is a mRNA or messenger RNA, and that is the messenger RNA, when it's that portion of that messenger RNA is introduced into the body, it does not, from what I understand, interact with your DNA.
Wow.
From what I understand. Now, the thing of it is, hold on, and that messenger RNA does not contain any, and I've heard this out there, any robots attached to it, does not contain anything that would be tracers that would identify people and where they're going. It doesn't contain any of that. So, Dr. Devaste, can you help us out, or anyone else can help us out as far as this question? Because I know in our community,
it's a big question. There's a lot of reticence of people taking the vaccine because it is an mRNA vaccine. This is the first time in the whole history of humankind that this type of vaccine has been introduced. So we do not know what's going to happen later. Now, I'm not saying that it will, but let's assume that the mRNA can go back into the DNA of us and then change a few things that we do not know. What would be the long-term consequence of that? No one knows. No one knows. So if someone says, well, I am not going to take the vaccine because of that reason, I don't have any logical reason to tell him or her that you're wrong. We do not know. So we have to expect the good and the bad, or what may happen.
Yeah, the way I look at it is that there is, and I said this before, there's the devil that we know and the devil that we don't know.
Exactly.
And, and we know how devastating COVID has been to the African American community, be it because of the fact that many of us are overweight or obese, or because diabetes and hypertension and heart disease is so prevalent in our communities, or, it just may be for other socioeconomic reasons, because we're more frontline workers and we are a person at the grocery store that's interacting with people all day long. But the thing of it is that that COVID, this disease is wreaking havoc on our communities. And I'm talking about not only getting the disease, but the death from the disease. So that's the devil that we know. All right.
But
the devil
what are we doing?
Is how the vaccine, if this vaccine on a long-term basis, 2 years, a year or 2 years from now, will show some type of effects that we don't want to, that we're not aware of at this particular point. So
I'm not recommending.
Omar, let me just say one thing. This particular vaccine is developed to create an immune response against a particular part of the coronavirus.
Correct.
If you've seen those pictures of the coronavirus, you see those spikes or those things that stick up. That's the way that it sort of attaches to the cell and gets into the cell. And so what they have done is they have looked at a protein that's part of that spike. They put a lipid envelope around it.
Right.
And that's what is injected. And that's what you're looking to develop antibodies against. And so to a certain extent, when you think about what it's doing, it's trying to, and when they talk about effectiveness, it's trying to prevent a lot of the disease and complications associated with the infection. So it doesn't necessarily prevent the individual from getting infected, because they still may get the virus, but it'll start to attack that protein and diminish the ability of that virus to replicate or reproduce itself within the cell. And so a lot of the people that might get COVID after having the vaccine don't have significant disease. They may not have any symptoms at all, but it doesn't necessarily prevent them from being infected. And it really doesn't necessarily prevent them from infecting someone else, because you may still have the virus. But the idea behind it is that as it starts to attack that spike protein, it will decrease the ability of it to reproduce. And therefore, if you have it, the numbers that you will produce will be a lot less, and therefore make you less likely to cause infection to others. So we're not talking about anything that is likely, and I can't say never, to insert itself into an existing DNA of the person. So I mean, you can say anything is possible, but when you talk about the ways that sort of things work, we don't know. We don't know if the virus itself could insert itself into one's DNA. We just don't know. But for the most part, we don't think that this vaccine is likely to insert itself into the DNA, because what it's supposed to be doing is to promote this immune response, not just antibodies, but also some of the white cells that help to fight and get activated when it sees the virus coming around. And so this idea is you get the vaccine, you get primed with that first dose, and just like when you're young, you take DPT, diphtheria, pertussis, and tetanus. You take a primary series at 2, 4, and 6 months, and then you take a booster. Once you get primed, and 3 weeks or 4 weeks later, depending upon the Pfizer or the Moderna, you get that second dose. There's a tremendous, it's called an amnestic response. It means that there's memory that exists. And once you now see it a second time, there's a tremendous antibody response and immune response to take it out if you now see it. So there'll be a lot of immunity that might exist to help attack the virus when you see it again. There's some thoughts about whether or not that first dose might be enough. Well, if you think about it, if indeed you've been primed and you happen to get exposed to the virus sometimes in the future, you might have a pretty big response to that as well. Whether or not that's going to prevent you from having disease, no one studied or not. But the president is talking about releasing all the vaccines so that everyone gets at least that first dose, and hopefully trying to get increased production so that you can get the second dose. But once you get that first dose, there's a certain amount of immunity that exists, and you're primed. And if you get exposed, or if you get the second dose, there'll be a much larger response that might be helpfully in terms of preventing you from getting very, very sick with the COVID.
Yeah, hold on, Dr. Luya, just to add on to that just a little bit. The thing of it is that, and I do critical care medicine, I see the devastation of African Americans and what we're going through as a people from this virus. And my thing is that I know as a history, we don't trust, a lot of the medications and a lot of things that from the medical community. But this virus is it's creating such havoc in our communities. I do recommend for each and every one of us to take this vaccine, because it's one way that we can be as assured as possible from a medical standpoint that the people that, and as you said, Dr. Sprott, it may not protect you from getting the virus, but it may save your life. And that's what it's all about. Right. Can save lives.
Right.
Dr.
Let me add a little bit to this. Great talk and explanation, Dr. Sprott. As a matter of fact, often enough, necessity is the mother of invention, they do say. It has become really necessary that, the technology of vaccine production become ramped up because of the unprecedented death that we've had, the devastating effect, not just, health, economics, and even social and mental issues as well that's come up. So the technology went up. Now, I also say this again, information is power. If you know, it calms you down, makes you understand issues. Now, the technology of mRNA is not new. Often enough, it has just been brought to, the surface right now, and being applied to vaccines, and that's why people are talking so much about it. The whole journey, I might say, actually started in 1976, where the lipid encasing that's been used to envelop this mRNA was actually published by a gentleman, I've forgotten his name, Loeffler or something like that, in 1976, and he was ridiculed when the whole thing came out. Now, the mRNA itself was actually designed or discovered in California Technology, Caltech, I think in 1965 or so. So it's been coming since then. But the breakdown of the mRNA for the use in vaccines, what we know now, was actually started by a doctor, she's Hungarian, Catalina Carico. She started this whole technology in UPenn. And when she published her papers and all that, she was actually ridiculed. As a matter of fact, she was demoted because they thought it was crazy and it was mad, the concept of which she was thinking. And that when she did it, she actually thought that we do this so that we can help treat metabolic diseases. That's what her intention was, not for vaccines, to treat metabolic diseases like, arthritis, even diabetes, and hopefully in the future, cancer. But then when the whole issue of the COVID and the deaths were coming, people started looking around and then started talking about what they need to do. So and that's why, minds came together, pulled this all out, and this is what we have right now. Now, I say this when I explain to my patients, the mRNA vaccine, it's an upgrade of your technology. Because if you see the phones that we have right now, it's very different from the phones you had a year, 2 years, even 10 years ago. I mean, we had the flip phone. All you just did, your dial and call. And then came, the phones where you can text. And then came the phones where you have ability to get on the internet. And then came the internet, you FaceTime. So these are upgrades of technology. So if you have to choose a technology, this is truly a remarkable technology that's leapfrog us into the future. Again, I always say there are good outcomes, bad outcomes. What are the outcomes for this? We don't know yet. But the chances that this will go into your DNA and alter your DNA, no, it wouldn't. It may alter how your DNA is expressed. If you all remember, I often say the word, what do you call it? The epigenetics that we always talk about. The food that you eat alters the way your DNA is expressed. The environment you live, the altitude. So would this affect that? Probably, most likely not.
Yeah.
Because the mRNA are messengers. They're just key messages, as compared to using the whole virus and injecting a part or a key portion of the virus into you. And
all right.
Okay. I would like to.
All right. Let's Dr. Devasty. And then after you, I'm gonna ask get with some more questions because we got quite a few COVID questions coming up.
I would like to say that I'm not against vaccine per se, but we have to look at things in the scientific way. It doesn't, what I just said doesn't mean that it will have some bad effects on human beings. You just mentioned that there are some things that can have an effect on our genes that can really adversely affect our genes. We know that. We see this in GMO. There's nobody who can say that the GMO doesn't have any effect on the genes. Roundup is causing right now a whole bunch of non-Hodgkin lymphoma that the company is paying billions of dollars for those things that they've been using as pesticides. So we know that. So we just cannot say it's not going to cause any harm. I don't know if it's going to cause any harm, and I would not tell patients not to take the vaccine because of what I just said. But we have to be clear. And the other thing two things that I want to add. You may not know that any vaccine you take in the United States, if you drop dead or anything happens to you, you have no legal recourse in the courts. You cannot go after the pharmaceutical company. They have complete immunity since 1986. You cannot sue them. You could go to federal court for relief, but you cannot go after the pharmaceutical company. That's the only product of its kind that has no liability, zero. Even if it kills you, you cannot do anything to them. I would be wary by just rushing to take some. I would agree with the vaccine, but we should keep our eyes wide open.
Yeah.
Yeah,
Okay.
Omar, if I may just say something real quick.
Go ahead, Dr. Anderson.
You know, the whole thing, I think part of the problem is, you know, we're commenting on an end result without an understanding of the history of the technology and the history of the process. And we've gone from injecting live viruses into people and to create an immune response, like Dr. Scott said, to injecting attenuated viruses to create the same thing, to isolating the DNA sequence of the product from the vaccine, or a segment of the spike protein of the vaccine that creates an immune response, to actually synthesizing a copy of that sequence and putting into people to create an immune response. And the history is interesting, but you know, to make it people understand, they also have to understand the history of viruses and how viruses function. So what we do know, DNA viruses, RNA viruses, you know, we worry about getting a virus which will change the basic genetic structure of the cells and make cells function differently and ultimately lead to illnesses. And we now argue over technology that creates a molecule or a DNA RNA sequence that can go into a cell and adjust the cells so that the body recognize a foreign entity and be ready for it. And it's an interesting conundrum because it's goes to be to speak to, you know, belief kills and belief cures, right? If you believe the vaccine will help you, then you will take it. If you believe it'll kill you, then it might just do that just by virtue of remaining at risk for getting the disease. And Dr. Clark can allude to this. We struggle the same thing with cancer therapy. Oh, radiation kills all my good cells. Well, you know, historically, maybe it killed a lot of good cells, but the technology now is just that it's focused. It's the same thing with chemotherapy. It goes in your system and it knocks off your goods. There's some truth to it. But now we're at the point where we talk about targeted therapy. To put it simply, we all want to go to heaven, but no one wants to die.
Patrick, could you just, you know, I think it's a good parallel. The human papillomavirus and its association with cancer, and how the vaccine is designed to prevent cancer. You know, and that's part of the issue. You know, the virus itself can cause cancer. And so the issue is whether or not, when you talk about a vaccine, a piece of something like that might prevent cancer, if you will. So could you talk about the human papillomavirus and its relationship to cancer in both male and female?
So, you know, we know the HPV, human papillomavirus, there are many subtypes, and there are the low risk groups, which will generally cause, you know, warts. You see in steel workers' hands, you get warts on the fingers. Those, you know, are cellular changes that occur that is annoying, but don't really kill you. But then there are the several high risk groups, it's about 15 or so of those high risk groups that will ultimately cause cancer. And it can be cancer of various parts of the body. It likes what we call epithelial cells, and epithelial cells are cells that cover entities. So that's the skin that lines the gut, you know, like the anus, the vaginal vault, the penile, the end of the penis. And when get infected, can ultimately become cancerous. Fortunately, it's a process. So once you recognize that there's an infection, there are often non-invasive ways to treat these quote unquote precancerous lesions. But when they do become cancers, they can be devastating. And these cancers, you know, cervical cancer, the mouth of the womb, vaginal cancer, the entrance to the vagina, the vulva, the rectum, the penis, the nostrils, the throat, the tongue. So affects many parts. So now we have vaccines, which they're not RNA vaccines, but it's a similar technology that can prevent this cancer. And we've seen over the last 30 years, a marked decline in the incidence of these cancer because we're starting recommending vaccinations for young women and young men up to the age of 45. Now, you know, there's also a social commentary that comes with that. Well, if you give them vaccine, you take away the scare factor and they become promiscuous. Well, again, here we go. You know, you don't want to get the disease, but you don't want to use the vaccine because there is, you know, some other thing that you know will make them some ethically behave unethically. You know, we can't have it both ways. But to Dr. Sprock's point, you know, these viruses, they cause cancer. These cancers are devastating to young people's lives, their quality of life, their productivity. And we have a cure for it. And the cure is really prevention. And that prevention is vaccines. Now you can argue that, well, what about behavior? That's only part of it. With behavior come compliance. With vaccines, once you have it, you know, it takes away part of the compliant conversation.
All righty.
Let me make a general comment though, based upon the previous discussion. I think that we as the professionals with much knowledge of these diseases have a role, a very important role, not only by example, but clearly in leading our patients towards a specific decision that we would like to see occur, not merely in terms of, here are some facts and I'm going to leave it up to you, but we like to guide them a little bit more. What I would like to say is this, that certainly our knowledge of the disease as well as of the vaccine, they're both very limited. We cannot argue or espouse the long-term potential consequences of the vaccine. So while I'm not prepared to defend that, I'm also not prepared to defend the long-term consequences of the disease, even in people who survive or people who have few symptoms. We're seeing more and more people because of the widespread testing. There are more people who seem to be aware of benign effects of the COVID acutely. And we say, well, doesn't touch had COVID positive, etc., but they did fine, etc. I want to remind you that you should mind your patients as we look very closely at people who have had supposedly minimal or benign effects from the COVID, that we are finding long-term effects. And let me quote you a study that was published on about 70 young men who had COVID in hospital and did not have COVID of the heart. They were diagnosed in hospital and released supposedly well and cured. Using very elaborate tests of the heart, MRIs of the heart, we found that not a minority, but a majority of these patients who had been exposed to COVID had abnormalities of the structure of the heart that could have long-term consequences. We do not know, but who wants to take the risk? We do not know if this will lead to so-called myocarditis, cardiomyopathies, and congestive heart failure in the long term. It is possible that 20 years, 10 years down the road, we may see an increase in the amount of cardiomyopathies, that is impaired function of the heart muscle, weakness of the heart muscle, and actual heart failure. So the unknowns are not only of the COVID vaccine, but of the COVID disease itself. And I unquestionably, unhesitatingly suggest that in terms of risk-benefit, I would, without question, stand on a soapbox and recommend to my patients that given what we know now and what we suspect of the future, that the vaccine should be taken where feasible.
I would like to mention a few things about prevention. There's no prevention. No one talks about prevention. We're talking about vaccine, fine, take the vaccine. But even if you take the vaccine, it will not prevent you, at least at the beginning, a few weeks after you take the vaccine, you will not have any protection against COVID, no protection. My problem is this. You identify a patient with COVID, the patient is not sick enough to go to the hospital, you send the patient home. and well, I do, most patients do nothing, not one thing. No medication is prescribed, nothing is recommended for prevention. Why don't we use some natural medicine? I do, to give the patients when they are diagnosed with COVID to minimize the likelihood that they will be hospitalized in a few days or a few weeks. This is not very difficult to do. This costs few pennies, and those things are accessible to the patients. They don't even need a prescription. They can go to any health food store and buy those things. The Chinese published in less than a year ago that they gave COVID patient intravenous vitamin C, 50,000 milligrams a day. Now everybody will scream and say, well, are you kidding? They will put you in jail if you give that amount of vitamin C. But the studies have been done over the years when in cancer patients who have been given intravenous vitamin C in very high dose. I've given patients 75,000 milligrams 3 times a week. No one has died because they have taken too much vitamin C, either intravenously or by mouth. By mouth, I recommend that. If you take too much vitamin C, they will soften your stool, and if you persist, you'll have diarrhea. If you have diarrhea, you just stop, and then you don't die because of that. So there are a few things I would briefly would like to go over that we should recommend to the patients if for prevention of COVID, or if they have COVID, what you can give them in terms of natural medicine. First is vitamin C. There are many articles to show that vitamin C has powerful antiviral effects. Vitamin C is also an antioxidant. So vitamin C can regenerate other vitamins that you're going to eliminate, so you can regenerate them. So vitamin C is very important, and you need high dose because once you have an infection, any type of stress you have will increase your use of vitamin C. One of the cells in the body that have the highest level of vitamin C is a neutrophil. Neutrophils, when they engulf a microorganism, they kill them by oxidizing them, and they need the vitamin C to do that. Without the vitamin C, we are a very bad disadvantage. So you need to increase the level of the vitamin C in the neutrophils. So how much? Well, 2 to 3,000 milligrams by mouth every 2 hours. If the patient gets diarrhea in the meantime, you tell them to stop, and next day take one dose less that caused the diarrhea the previous day, so they will not have diarrhea. Now, vitamin D, I mentioned that high dose. If they don't have COVID, high dose, 5,000, 10,000 international units a day would help. And then selenium. Selenium is really important in so many different ways. Selenium helps the body to crank out T cells. If you don't have enough T cells, you cannot fight COVID. This is why I recommend selenium for HIV positive patients. By the way, I've never lost one patient with HIV. I've never cured anybody with HIV either, but no one died with a natural protocol. None. They all gain weight. They all go back to work. They're not cured though, but they can function. So selenium will increase your T cells, will increase the activity of your immune system. In addition, selenium is part of an enzyme called glutathione peroxidase. That is a very high enzyme that is needed to neutralize peroxides that you produce throughout your body because of infection. So selenium is an important thing. Magnesium is also very important because without the magnesium, the magnesium is involved at every step in the synthesis of vitamin D. From the time you start with I don't have to mention the name because it's too technical, but every step of the synthesis of vitamin D, magnesium is there to help. So you give the patient magnesium. They don't have to take a lot of magnesium. 200 milligrams of magnesium twice a day would be more than enough. And then zinc. Without zinc, you need zinc to help your immune system. Zinc also inhibits the enzymes that crank out the virus. So you would be able to inhibit the enzyme that cause the virus to reproduce. So that would help you. If you do that in high dose, one last thing. I recommend a second type of vitamin C, which is called liposomal vitamin C, which is lipid soluble vitamin C that can bring the vitamin C in all the recesses of your body, because vitamin C, is a water soluble vitamin C. So there's some places they may not be able to get it because the fat content is too high. So if you combine that with a fat soluble substance, you can drag the vitamin C inside every area of your body. So you can bring the effect of vitamin C very high. But this vitamin C does not cause diarrhea, unlike the capsule or the tablet. So of course you have to know which one to recommend, but you get the idea that if you put a patient on this protocol, they should do well. You should prevent them from going to COVID to a point that they're going to need to be in the ventilator. And if they did that, one last thing that I want to mention, in many articles published in the medical literature, that a substance called ivermectin. Ivermectin is a medication used for worms, for parasitic infestations. It's been on the market since 1975. There are many articles published to show that ivermectin can be very much important in COVID. And there are different phases of COVID. The phase 1 is the proliferation phase, where the virus multiplies in your nose. Phase 2 and 3 is in your lungs. So remdesivir that they use is good for phase 1. So if you have a patient who goes to the hospital and the patient is having problem breathing, there's no point to put the patient on remdesivir, because the patient is no longer on phase 1. The patient is on phase 2. The phase 1, after you produce high amount of viruses in your nose, they go down in your lungs and they die. Once they get in your lungs, they create a reaction from your body that creates a cytokine storm. So if you're just putting everyone who come to see you on remdesivir, and if you do not know what phase the disease this patient is on, it's not a good treatment. So for phase 1, you can give remdesivir. Phase 2, you can give decadron or dexamethasone. But there's no need to give remdesivir if the patient is on the ventilator, is not able to breathe, because you pass the first one. The proliferation phase of the virus in your nose is gone. So there's no point to try to inhibit replication of viruses, because you don't have a lot of viruses being replicated in the first time. These are really important stuff. Ivermectin is available dirt cheap. This medication works in all the phases. Vitamin C works in phase 1, phase 2, and phase 3. No matter where you are in the disease, it would help you. So we need, as physicians, to bring this out and to understand that we don't have to wait to use all pharmaceutical products, that they are natural products available to all patients without any prescription, that if we use them, we will reduce the death of patients that are severely afflicted by COVID.
Yeah, thank you.
Omar, I
Thank
have a
you.
question for Dr. D.
How about
Omar.
N-acetylcysteine?
Who's
Yes.
speaking? Who's speaking?
Somebody said they
Dr.
had a
Fredericks
question.
and then Dr. Court.
How about N?
Dr. Fredericks?
Hey, Doc, good to see you. I heard NAC also helps. Does NAC help?
Yes, N-acetylcysteine is a great idea to use because it is a precursor of glutathione. Glutathione is made of cysteine, glycine, and glutamic acid. So if you give N-acetylcysteine, we cannot take cysteine, by the way. You can take N-acetylcysteine in this form. You could give that to them, and then that will help them increase the level of glutathione. Glutathione will be very important because glutathione is involved in glutathione peroxidase that helps
You're a
us to
little too
deal with
technical, I think.
onslaught of
All right.
the oxidative stress.
All righty. Thank you. Dr. Court.
Okay, Dr. D, from your accent, it appears if you're from the same part of the world that I'm from. In Guyana, where I'm from, people believe in so-called bush. I don't know if you've ever had any interaction or discussion with patients in terms of using the bush for treatment of COVID, because patients will tell me, oh, Dr. Court, I use some ginger and I use garlic and I use
Yes.
one of the other concoctions, and they work. Is
Yes.
there any medical basis for that?
Yes, I'll give you an example. I'm from Haiti. People should be dying like flies in Haiti with COVID, but that's not the case. Have you heard that people in Africa that are just dying like flies, because of COVID? No. Why? Because they're using botanical medicine. Now, we frown on that, but we understand that those things have good therapeutic value. For instance, garlic, like you mentioned. I prescribe garlic, refined garlic. It's not the garlic you can get in the market. They refine it, they extract things, and they put it in a pill. So patients who come to see me who have severe infections who are not responding. I had this patient with pseudomonas in the lungs. She was not responding to anything. I put her. This is expensive. I put her on that garlic extract. It took it away. In less than 3 months, everything went away. Now I'm
How
not
do
saying.
you know how much garlic to give the patient? When they boil these medications, you
No, no, no,
cannot
no, no.
tell
We're not
if
talking.
it's a
No, we're
cup
not talking
full
about.
or what.
We're not talking about getting garlic from the store.
Sure.
I'm talking about a company that makes garlic, extract the garlic and put it into a capsule and quantify into a pill. You know how many milligrams that you're giving, and then you give the patient that garlic, and they do very well for any infection. I've had some great results. I'm not saying to just take that alone. Maybe you can combine them. They do well. For instance. There's a substance that I use for so many things. Anyway, the name will come to me. It's really helped in reducing infection by reducing interleukin 6, nuclear factor kappa B, interleukin 1B. Those are all involved in infections. So when you have the infection, all those things are going to go up. And then there's some natural substance that can bring them down. So interleukin 6, for instance, is known to be very high in multiple myeloma and many other cancers. So you can use those things to reduce the level. It's just, it's all there. It's all there. They are published. If you want to go to PubMed and put, for instance, intravenous vitamin C and cancer. Just read, or vitamin C and cancer. There are more than 20,000 articles. So when they tell you they have no scientific data, it's because maybe they're not looking at the data. It's there. There are so many articles.
Okay. Now, at this particular point, we're a little over halftime, and I just need to, for those people that joined and joined late and did not get the introduction of our physicians, that's what I'd like to do. And let me just do a few other things here. Just give me a second. All righty. So I'm going to reintroduce our physicians, number one, and number two, then we're going to do a few other things and keep going, because these conversations are actually great. And I'm so glad that Dr. Devasty is here, because we are traditional medicine physicians. He's a holistic as well as a natural medicine. We don't come in contact with this aspects of ways to treat different diseases. So it's important that we get knowledge and the community gets knowledge, because a lot of my patients that come in, they use natural medicine. So it's so great to have him here today. Dr. Court, can you start off? Can you introduce yourself, please?
Dr. James Court, Howard University, class of 1980, Washington, D.C. I've in private practice in East Orange, New Jersey.
All right. And Dr. Devasty, please, Gerard Devasty.
Well, Gerard Devasty, New Jersey Medical School, internal medicine, and board certification in integrative and holistic medicine, practicing for more than 30 years.
Thank you. Dr. Atherley.
Trevor Atherley. I'm an interventional cardiologist practicing in Essex County, predominantly at Newark Beth Israel Medical Center, where I'm a teaching member of the Faculty of Cardiology.
All right. Dr. James Lee.
Dr. James Lee Jr., second generation orthopedic surgeon, born in Orange, New Jersey, practice in West Orange, New Jersey.
All righty. Dr. Fredericks. Dr. Fredericks.
Dr. Dwayne Fredericks, bariatric surgeon, weight management specialist, went to Lincoln University. Now I practice in South Orange.
Dr. Kendall Sprott.
Morehouse College class of 73, New Jersey Medical School class of 77, board certified pediatrician, pediatric critical care and general pediatrics.
All righty. Dr. Nelson Aluya.
Well, Nelson Aluya from the great University of Ahmadu Bello University, Zaria in Nigeria, assistant professor of medicine at the New Jersey Medical School in Rutgers here in New Jersey, also an attending physician at Newark Beth Israel Medical Center, medicine and pediatric trained. Thank you.
All righty. Dr. Patrick Anderson.
Yes, Patrick Anderson, graduate from Rutgers University in Newark, went to New Jersey Medical School with Dr. Devasty, mentored by Dr. Sprott and Dr. Omar Bey, Dr. Atherley. Albert Einstein College of Medicine for my residency in obstetrics and gynecology and fellowship in gynecologic oncology. Currently chief of GYN oncology at North Beth Israel Medical Center. Glad to be here.
All right, thank you, Patrick. And Dr. Kevin Clark.
Dr. Kevin Clark, surgical oncologist. I work with Dr. Anderson, Dr. Bay, and Dr. Court, Dr. Luya, and Dr. Athley at Beth Israel.
All righty, excellent. And I'm Dr. Omar Bay. I'm pulmonary critical care with a subspecialty in nutrition. We are here every second Saturday at 1 o'clock. So please tell family and friends to tune in, and we will be discussing all medical matters, and we will be answering medical questions. This Zoom webinar can be, you can come on at OBHealthy and just click the Physicians Health Network, Physicians Network button at the top. Most important, do not change any aspect of your medical care until you consult your physician. We're here discussing many medical problems, many ways to treat things and treat those medical problems, but your physician is the best one to know how to take care of you and your medical problems. So do not change any aspect of your medical care until you consult your physician. Understand that we're on YouTube. If you miss any of today's webinar or any of our other webinars, you can go to OBHealthy and click on please subscribe so we can continue to bring these webinars to you. I'd like to thank OBHealthy for allowing us to use their platform so that we can bring this information to the public. All righty, let's go with another question here. I am 73 and registered for the vaccine. I am allergic to Negram, it's Negram, and spinach. Would that be a problem for me taking the vaccine? Can anybody comment on allergies in the vaccine? I do know that, and I was on a webinar the other day, and they were stating that if you had serious seafood allergies, that there may be a problem. But that was the only allergy that they were talking about. I don't have any knowledge of other allergies that would inhibit you from or prevent you from getting the vaccine. Can anybody chime in on that?
Yeah, I think that there's, again, this is a novel virus, so that means it's a new virus, and these vaccines are even newer. I think that the Pfizer vaccine is a vaccine that there were several what we call anaphylactic reactions, and these were individuals that were highly sensitive that carried around EpiPens, which is epinephrine, an injectable that helps reverse some of the symptoms of that kind of allergic reaction. But what they're doing now, and Moderna, which is the second vaccine that was released here, doesn't have the same kind of warnings are related to that. But what I think most people are recommending is that if you go to have a vaccine, you have to wait around 15 minutes afterwards to see if you're going to develop any reactions. And if you really have had significant allergic reactions, they make you wait an additional 15 minutes. So they make you wait 30 minutes. So I think that there's no contraindication. That means that there's no one that shouldn't get the vaccine. They just want to make sure that if you do have allergies, you hang around so that they can treat you if you have a reaction.
Mm-hmm. Very good answer. Yes, thank you. There was a next question. We got quite a few questions, so I'm going to go through some of them. The next one, what recommendations can be given to guard against issues concerning the prostate? That's a pretty vague question considering the prostate, but I understand issues may be urgency, it may be difficulty urinating, it may be, can someone expand on this a little bit?
Repeat the question again.
The question was, what recommendations can you give to guard against issues concerning the prostate?
Well, there are quite issues concerning the prostate. One of the things besides the hypertrophy of the prostate is prostate cancer. There are many interesting articles. I mentioned that last time, and I will mention that again this time, that there were studies done to show that if you introduce zinc, I said that what's his name was there, zinc will prevent the formation of cancer cells in the prostate. What they did, they gave they give the zinc to animals by mouth, and it didn't work. And what they did, they injected directly the zinc directly in the prostate, and they were able to prevent the cancer. I've done this for many patients who had biopsies or had precancerous lesions in the prostate, and I combine a natural medicine, a natural substance, to help them incorporate the zinc in the prostate. There are two areas in the body where you have the highest levels of zinc. It's the eyes and the prostate. And nature does not put anything someplace because of no reason. So the zinc is there. We know in the prostate tissue, as we get older, the zinc level diminishes. And specifically in Black men, there's a transport system that does not function properly that increases the risk of having prostate cancer because of a low level of zinc throughout the years. In a BPH, in an enlarged prostate, there's 65% less zinc compared to a natural prostate. In the prostate cancer tissue, there are 80% less zinc in the prostate compared to a normal prostate tissue. So zinc plays a very big role in the prevention of cancer. The trick is to do is what to take with the zinc to incorporate the zinc in the prostate tissue. And what kind of zinc? The zinc I recommend is called zinc monomethionine or zinc methionine. That's the highest absorption, combined with a few other things that would to incorporate the zinc in the prostate and to play the trick. This is what I do. And of course, with vitamin D. If you have a low level of vitamin D, you increase your risk of prostate cancer. So vitamin D and reduction of consumption of certain fat, specifically eggs. So you do that, you take care of yourself, you minimize your risk to have prostate cancer.
Alrighty.
May I just ask Dr.
Go ahead.
Devasti? So the things you just speak to primarily is environmental, physiologic milieu issues. How can you speak to how these might help in patients who have genetic predispositions to these malignancies?
Well, genetic predisposition of cancer is only what, 10%? It's not even 80% of cancer. Most cancers people have are from the environment. They're not from genetics. BRCA1 and BRCA2 accounts for about 10-20% of breast cancer. So it's not really that you have a lot. But what you can do, this has been published, this is in New England Journal of Medicine recently, that if you consume a tremendous amount of fruits and vegetables, organic fruits and vegetables, in the form of juicing, you interfere with 2,000 genes in your body. This was unbelievable. I was so surprised. This was published in the New England Journal of Medicine talking about fruits and vegetables for prevention of cancer. Now, they recommend the juicing because the juicing gives you, well, if you do the juicing, you concentrate thousands of things from the fruits and the vegetables and you drink it. You cannot get the same results if you're eating the fruits one after the other. You don't get that invasion with the fruits, with the juicing. So you do the juicing and you do not consume any fruits or juice, any fruits or vegetables that you have an intolerance to. You stay away from them and you consume that. This is not something that is very difficult to do. That I do some juicing almost every day, and it's very helpful for me. Reduce many things, including colon cancer, because you have such a good source of fiber. So it's really not very difficult to do.
That's what I was going to ask you. With the juicing, do you take the fiber out when you juice?
I do. I take the juice and I use a very cheap juicer, and I tell patients doing the juice, using the worst juicer there is always better than no juicing at all. I don't care what juicer that you're using, but if you're using something, you could use the pulp, you can drink it, or you could spend a lot of money to get a juice extractor. You get the most expensive one will cost you about $2,000. It's called the Norwalk juicer, but most patients do not have that kind of money to spend $2,000 on the juicer. So you could go to any place, get a juicer for $150. You drink the juice and the pulp, and it's I have never heard anybody just drop dead because they drink too much fruit and vegetable juice. It doesn't happen. So there's no problem.
Let's go on
Clark,
with some
just a question about
go ahead, Dr. Sproul.
Any evidence about regular sexual activity and decreasing the risk of prostate cancer?
Actually, I read an article that said that it did. because one patient, I'm glad you brought that point, Dr. Spratt. One patient came with his wife to see me, and he told me that he read that increased sexual activity would reduce the risk of prostate cancer. For that reason, he wanted his wife to have sex with him as often as he would like. Of
Hey.
course, the wife did not go for that, but he had a point. Yes.
Yeah, he does.
Yeah, I think that there are some studies that have looked at it, and I think there is a relationship. It also helps if you just have, not multiple partners. But part of the thought was that some carcinogens that might be there, if they're removed, might decrease the ability of them to cause
Correct.
cancer.
That is the point. Yes,
Yeah.
that's correct.
All right. There are some more questions coming up. There are quite a few. Is there a favorite brand of the vaccine currently available? So do you favor one vaccine over the other?
The last one, AstraZeneca, because AstraZeneca does not have to be refrigerated at very low temperatures compared to the previous two vaccines. So for transportation, logistics and everything, it makes it easier, not because of the intrinsic value of the vaccine itself, but because storage and everything makes it easier.
Yeah, I know the Moderna vaccine also, it doesn't have to be super cooled as well.
Right.
So those sites out there that are not able to super cool the vaccine, for instance, the health departments and community centers and stuff like that, they're getting the Moderna vaccine. Places that major hospitals, a lot of them will have the Pfizer vaccine because they can super cool. I do know that.
The Johnson & Johnson vaccine is supposed to be one dose. It's not yet approved here, but it probably is going to come up for authorization probably within the month.
Right. Okay. All righty. And let's see. There was something on. Okay. I'm just trying to get some of these questions out of the way. What makes bladder cancers grow? Now, this is a little vague, but can you help us out? I think they may have been directing it to Dr. Devasty, maybe. Is there issues with bladder cancer or that makes them grow as opposed to other cancers? Or
bladder cancer, there are two
understanding of that?
There are two main types. We don't have to go into the details because, but the most common one is known to be associated with certain types of dyes and other things that you can have. So bladder cancer is known to be has a very high recurrence rate. So you remove it, and they have cystoscopy so often because they can have a recurrence. But there are some mushrooms, for instance, that have been known to be very helpful in bladder cancer. One of them is called maitake, which is the name is Grifolia frondosa, which is available many places that can help. Vitamin C is very helpful. So a combination of few things can get great results in bladder cancer. But that's the one that is the least aggressive. The more aggressive one, I haven't seen any natural medicine that can do anything. They have to have surgery and have chemo.
Yeah, one of the things that I know is being used is BCG, which has been used primarily for tuberculosis. But they're putting the BCG into the bladder, causing sort of an immune reaction. It's a form of immunotherapy causing that local reaction. And that's been, I know that they're using that in Texas.
The maitake, I said, is just this boost your immune system. This is exactly the same thing with a different route. You boost the immune system, and then you deal with the cancer.
Yeah, BCG and other topical or intravesicular treatments are done for superficial lesions. If you have muscle invasive bladder cancer, that needs to have a cystectomy.
Yes, that's what I'm saying. So the most aggressive form, I didn't want to go into all the details, but the most aggressive form, you need to have surgery and take chemo. I would use a combination of the three, but natural medicine alone would not be a good idea.
Dr. Devasty, I have a question.
Go ahead.
You're touting use of vitamin D. Have you ever seen a patient who has vitamin D toxicity, since it's fat soluble and not water soluble, as so many of the other?
Yeah, vitamin D is a fat soluble vitamin. I have seen patients, remember I just said that the upper limit of normal vitamin D is 100 nanograms. I've seen patients with 150, 175 with no symptoms whatsoever. So you rarely see this. So if you give patients a high dose of vitamin D, you give that for short period of time, then you stop. So for me, I recommend patients with COVID to take 50,000 international units a day for 3 days, every day for 3 days, and after you stop. I highly unlikely that you would see toxicity of vitamin D if you do it that way. But I don't recommend that for a long period of time, no.
There was
Dr. Devasti, if I may add a little bit here, what you have said, we've talked here a number of times over the months, the role of vitamin D with regarding to managing COVID-19 and then zinc as well, and all the steps that they work on. But my question to you is something that is ubiquitous, but most people don't talk about it. I'm sure it's come around in your radar from time to time, and they begin to really talk about it. It's another fat-soluble vitamin, that's vitamin K, with regards to managing or treating COVID-19. What's your take on that?
Okay. Now, vitamin K, there are three types: the vitamin K1, K2, and K3. Okay. So it depends on what you want to do. Vitamin K, K2, very good for things that do not have anything to do with COVID. I have not had a lot of use of vitamin K. It may be able to help, but I don't know for sure exactly what would be the mechanism of action and what would be the dose to give. I know I give vitamin K2 to patients with osteoporosis or osteopenia because the vitamin K2 cause incorporation of calcium in the bones and in the teeth. So if you just take vitamin D to help you absorb calcium, if you don't know how to incorporate that in your bones, you're not getting a good result. So you take the vitamin D and then you have the vitamin K2. And vitamin K2 for this is very low dosage. 100 micrograms would be the dosage. And they have different types of K2. So MK7 is one of them that I would use. So that will help incorporate the calcium into the bones and to make sure that you can calcify your bones and calcify your teeth.
all right.
Dr. Devasti, you mentioned that you do a lot of juicing. Are there any kind of metabolic detoxification that you do or help your patients with?
Yeah, well, there are certain things. The problem is that the testing that you need to do is expensive, and sometimes the patients are not willing, especially the insurance companies are not willing to spend any money because they tell you what you're doing. There's no science. They don't have this. They don't have that. So they're not going to do that. But there are certain things that you could give you an example.
Mm-hmm.
We know that for COVID, we have what is called the long haulers. In other words, patients that are post-COVID patients that are having some residual effect of the viral infection. They lose memory lapses, depression, pain. So why is this happening? I decided that I would just measure the level of C-reactive protein on those patients. These patients, I believe, have chronic inflammation. And so if you see the C-reactive protein, there are other things you can measure, malonaldehyde, but the C-reactive protein would be enough to see that you have chronic inflammation with this patient. And then the next step would be to reduce the level. If you really want to know, you can measure interleukin-6, you can measure nucleofactor kappa B, you can measure interleukin 1B and 1A, but nobody's going to pay for those things. So there's no point to try to go there. Just be satisfied with the C-reactive protein, and then I put them on very high dose of fish oil, which is a safe something to do. It will lower, and I can measure. This is the level of those things before the fish oil. This is the level after the fish oil. And in most cases, the levels of inflammation goes down, and that's translated into less symptoms and better management of the patient without giving anything that is dangerous or expensive. Of course, if the patient has, they cannot tolerate fish, you cannot give them fish oil. You
Sure,
can give them
right.
other omega-3s, but not fish oil.
Right. All righty. Thank you. There was a question, Dr. Atherley, and I don't know if there are articles out there on this because it's fairly new, as far as the long-term, you had mentioned some of the long-term effects of COVID and post-COVID, people having, effects ongoing. And they wanted to know what there are any articles that they could read or where they could get some information on it. I don't know if it's actually, we're anecdotally talking about it, or has there been research? It's pretty new. I don't know if there's research on that as of yet.
There was at least one study that I quoted. That is a study published in JAMA Cardiology, July 27, 2020. And this was an article which reviewed 100 patients who were post-COVID without any significant cardiac sequelae by way of symptoms. And it showed that about 78% of these patients did have objective findings of abnormalities on MRI. And MRI is a very sophisticated kind of scanning of the heart. They had objective abnormalities, which could portend serious illness in the future. The patients were not very symptomatic at the time. This was just findings picked up on very elaborate testing, but which could suggest future serious consequences. So that was JAMA, July 27th, JAMA Cardiology, July 27th, 2020.
Okay. There was another question that came through. Can I get enough vitamin C through orange juice and other foods?
No. That's a great question. No.
No, that was an easy question, right?
No. The question is, what is the requirement of vitamin C and what it is based upon? The requirement of vitamin C is based on mainly the type of stress that you are under and your weight. So if you are under a lot of stress, you need to take a lot of vitamin C. And how much vitamin C should one take? There are many physicians who have written about this, well authorities on vitamin C, who believe that the vitamin C should take that to the point of bowel tolerance. In other words, you take it until your bowels tell you you have enough. Any surplus you take will come out in soft stool or diarrhea. So what you should do is to find out what your point of saturation is. I'll give you an example. I had this patient. She was very short and didn't weigh that much. She could not tolerate more than 1,500 milligrams of vitamin C a day. More than that, she would have diarrhea. When she had a cold, she could go to 2,000 to 3,000 because the stress there caused her to rapidly eliminate vitamin C. So she needed a higher level. So the dosage of vitamin C you should take, it should be based on your need. So if you win the lottery, if you get married, you get divorced, you have death in your family, any of those things are stressful conditions. If you go to the hospital, if you have surgery, you need to take a good amount of vitamin C. Some surgeons now are putting some vitamin C in the IV bag after the operation, just to give the patient enough vitamin C to deal with the stress that they've gone through during the surgical intervention. So this is something that's very important.
Nowadays, a lot of IV hydration bars are coming up. They use that vitamin C as well.
Yes, they are using that now because they realize that it certainly will speed up the healing process and shorten hospital stay, reduce the risk of infection. So all those things will be great to have if you use vitamin C.
Right.
I think I think when you're talking about things like vitamin C, vitamin C was spoken earlier is water soluble, but for the most part, most people take it by mouth.
Yes.
And in general, the average person might absorb 70% of what you take. The more you take, then the less you absorb.
Yes.
Then that stays in your gut. What gets absorbed then gets into your system. Now, I think that Dr. V said that, depending upon your stress, in order for it to be used, it's got to be metabolized. But what tends to happen is if you don't need it, if your body or your cells don't need it, you excrete it in the urine. I don't know how many folks take multivitamins, but after you take your multivitamins in the morning and you go to the bathroom and you pee, you'll see that a good percentage of those water-soluble vitamins are in the toilet.
Yes.
So the real, just let me finish. And so I'm not sure that there's a good way. And as you said before, not many people take vitamin C levels to see what they are in the blood, because for the most part, it needs to work within the cells. And the real question is, I don't know if anyone knows exactly how much of vitamin C that you take is actually utilized by the cells. And so, people that talk about these large doses, I'm sure that in certain situations, your body may need it, but what your body doesn't need, it'll get rid of. And there is some danger it gets excreted as an oxalate, that there's a possible consequence of having kidney stones.
Well, this has been debunked many times, that taking high levels of vitamin C does not cause oxalate stones. Now, if you have oxalate stone to begin with, yes. But if you don't have oxalate stone to begin with, it will not cause oxalate stone. Because if it did, many people, it would be thousands and thousands and thousands of people would have oxalate stones. The other point is this. You are talking about what goes in your blood. The vitamin C goes into your tissues. Various tissues have various requirements. I just mentioned, for instance, that the neutrophils need a lot of vitamin C, because if they don't, they cannot fight infection. They cannot deal with viruses and bacteria. So other areas in your body needs a high amount. For instance, the eyes, they need a very high amounts of vitamin C. The lenses, this is one of the highest level of vitamin C in your body. Your brain, for instance, needs a very high amount. You won't see this in the blood, but they come out of the blood and go into the tissues. So the studies that were done to measure what would be the different levels of vitamin C in the tissues, and you have a good variation. So,
but Dr. V, my point is that no one is measuring vitamin C levels in tissue on a regular basis. And so
yes,
when
they have some studies to do that. Yes.
When you take it by mouth, it gets absorbed, it gets into the blood, and then it goes to the tissue. And the tissues that need it will utilize it. But what I'm saying is that we don't know exactly how much of the vitamin C that you're taking actually gets utilized and how much gets excreted. Because if it's not being utilized, it gets excreted.
And that is my point. So you can take vitamin C to a point where you excrete it, you cannot tolerate it anymore. And this is what they said. This is the point of biotolerance. Let me explain why. Let me explain why.
All right. I understand what you're talking about, and I think that this discussion can go on afterwards, but
give me less than 1 minute, I explain why. Less than 1 minute.
And my only point was that there's a difference between absorption and excretion. If you take something and it doesn't get absorbed by the gut, it gets excreted.
So whatever you take at some point is going to get excreted.
It gets absorbed.
Doctors. All right. Thank you. And what a great discussion. We can continue that one on afterwards, though. But just to chime in, as far as healing, I do TPN, or total parenteral nutrition, or feeding via the IV in the ICU. The Director of Nutritional Support. And we do put vitamin C, we put selenium, we put thiamine, as well as zinc into the IV, so that healing will happen post-surgery, or patients that come in with decubit eye can help that healing process. That is true. But we're going to move on. There's a question that comes, because we have so many questions. There's a question that came in, and Dr. Devasty, we have a lot of questions for you here. So I'm just trying to get through some of them, because the audience is really interested in this. To prevent colds and flu, I have a tendency of using antiviral essential oils and tinctures like oregano and eucalyptus oils and olive leaf extract. They seem to work well because seldom do I catch colds. Are there any studies that supports the use of these botanicals, or is it a placebo science?
I
think Dr. Devasty, we are losing you there for a minute. All righty. It's a great question, but we lost Dr. Devasty for some reason. I'm not sure. All righty. So basically what we'll do is we'll keep going. We'll get back to that question and hopefully he can answer it when he comes through. All righty. There was a question that came in. I have COVID. What can I take for the weakness that is associated with it? Can anybody help us with this one? I know that we're trying to.
I can chime into that because I got COVID and I have a first-hand experience of the profound weakness that comes with, you know, that crazy illness. I mean, I've never felt or seen anything like that before, and a lot of people have said the same thing too. As a matter of fact, before I got mine, somebody and a few patients had actually described it. It gives you such weakness that you want to sleep all the time, and a patient actually said it's like the sleep of death. So other than, you know, building up your immune system and reducing inflammation, because of course it has to do with the muscle weakness and everything else with the virus, and not just the virus, but the up regulation or overdrive of your immune system and the inflammatory process that's going on in the muscles. That can be reduced again with vitamin C and zinc and vitamin D, obviously, and of course a vitamin K, which Dr. Devasty had initially alluded to. And in terms of vitamin K, it's amazing. It's been used to treat a whole lot of inflammation. Doctors are using, surgeons are using now for wound healing, and it's been help with reducing aging and all that. So cranking up on all of those would really help reduce the inflammation that takes place. And of course, you have to get up. I've advised a lot of my patients, please, if you are sick with the COVID, you're gonna get this weakness, but please get somebody to get you up. Try as much as possible to get up, do some stretching exercises, and just try and keep hydrated. But you have to move, because the more you do, the more you stay in bed, the worse things get. I mean, for people who have been sick, there's what they call, you know, like they always say, if you don't use it, you lose it. So if you don't use those muscles, you begin to use it. And those profound fatigue is real and it's profound. And for those who eventually recovered, there's a recovery process. As a matter of fact, it took me about another week just to get back to my usual state. And for a few, I've had to send for physical therapy just to rebuild, you know, their muscles again.
Okay, thank you for that personal. I mean, you know, it's good to hear from someone that actually had the problem or had the disease and what they went through. And thanks for sharing that. We have something here. Will B12 and iron help my low blood count? Can anybody help us, Dr. Court, or we're talking about low blood count and taking B12 and iron, does it help?
It would help if you have a vitamin B12 deficiency or iron deficiency. If you do not have those diagnoses, it may not help you at all.
Mm-hmm. Okay, all right. And there are many reasons for anemia. Right.
Yes.
There could be loss of blood. It could be B12 or folate. It could be anemia of chronic disease. It could be kidney problems. Many reasons for anemia. I think they need to consult their physician, number one, and you know, and that's the start as far as trying to figure out why you're having anemia. There's another question. What is a murmur, and do you really grow out of them? It's Dr. Atherley. Dr. Atherley.
Okay. All right. A heart murmur is a sound, simply a sound made on auscultation, that is on listening to the heart with a stethoscope. Now, why do you have such sounds? These reflect the passage of blood through the valves and in various portions of the heart. To understand this, perhaps you need to go a little bit more, I have to move swiftly, into the anatomy of the heart. 4 chambers and valves separating the two pairs on the left side, the left and right atrium and ventricle separated by a valve, and on the right side, right and left ventricle separated by a valve. And the blood goes from the right side to the lungs through the pulmonic valve. And when it leaves the left side, it goes through the aortic valve to get to the body. So there are many valves, many areas through which the blood flows, which can generate songs if the blood flow is in some way affected. Now, in children, just the flowing of blood naturally may cause murmurs in more than 90% of these, and maybe 1% of children will have murmurs which are not innocent, but which are caused by serious problems. They can also have, of course, holes in the heart, so there are abnormal communications between the various chambers of the heart. So murmurs can be caused by a variety of different reasons. In adults, however, we may have to take them a little bit more seriously, and of course, in some children, where there are other associated features. In adults, we're more concerned about the valves sticking or the valves leaking as common causes of the valves. So in essence, I would say that the heart murmur alone is not an adequate enough description of what is underlying and problematic with the heart. What is required is to say what the anatomical or pathological, what the problem is that is causing these songs. And there are multiple causes, some of which can be very serious, some of which may be treated with medication, some of which may not require treatment, and others which may require surgical intervention, valve changing, valve fixing, or fixing holes in the heart. That's a very general concept. But if there is a defined heart murmur, it is important that you see your physician and get it checked, because it may not be enough just to hear that there's a murmur. One may require certain specific tests to visualize the heart with echocardiograms or other sophisticated tests to see what the underlying problem is, and then treat that specific underlying problem, which is causing the heart murmur. Don't treat the murmur, treat the cause of the murmur if it does require treatment.
All right, thank you, Dr. Atherley. Dr. Devasty, is your mic working now?
Yes, I can hear you.
All righty, good. Well, let's go back to that question. It said that the patient, to prevent colds and flu, and that she rarely catches a cold and flu because she takes these essential oils and tinctures, such as oregano, eucalyptus, and olive leaf extract. She wants to know, is it like a pseudoscience, or is there real substance behind that?
No. Olive leaf extract is excellent for cold prevention and cold treatment. Vitamin C, of course, vitamin C is in every gravy. So vitamin C would be a great thing to have. I think you mentioned something else besides olive leaf extract. You mentioned.
Yeah, there was, I'll give you a eucalyptus.
Eucalyptus is very good.
Olive leaf extract.
Yeah, those are great things to have. The only thing, olive leaf extract is good. Olive oregano is also excellent, but it has a very bad taste. Most people tend not to use it because I prescribe the oil, and you could put this in a little bit of water or juice. They're also very good for intestinal problems. If you have people have intestinal problems, intestinal infection, very bad, disturbance in the intestinal flora, it will be a great stuff to take. It's excellent.
Okay, excellent. There was a question that was, it stated, I was told recently that cabbage and kale has a high level of thiamine. I think that, I don't know if they spelled it right, I think that's thiamine. Do you have any,
I don't know the content, if they have high levels. I know cabbage and kales have other things. For instance, they have sulforaphane, just like, for instance, you see in broccoli, and they are very helpful. For instance, Dr. Anderson might be interested to know that in patients who have breast cancer, patients who have breast cancer that is sensitive to estrogen, one of the things that I would recommend would be broccoli capsules, because the broccoli capsules will speed up the elimination of the estrogen. So it will deny the cancer tissue of the estrogen that it is using. So it will be and it has no side effect, zero side effect. Besides, it has many other good activities. So this is one of the things you could use, broccoli. There's a building in Johns Hopkins Medical School that was built a few years ago because there's this physician, Paul Talalay, who has been doing research on broccoli for the past few years. He spent $2 million in a building for him to do research on exclusively on broccoli. And he's been publishing many articles to show the tremendous therapeutic effect of broccoli in so many different things.
All right. Hi, the next one. Hi, I'm rushing along because we don't have much time left. Hi, this is for the holistic doctor. I suffer from migraines. This is a lifelong issue. I am a female in my 30s. I've tried all sorts of medications with no success. Can you recommend a natural treatment or a supplement I can try?
Yes, magnesium. One of the reasons you see this in women, so when they have their period, they increase the loss of magnesium in the urine. They lose a lot of magnesium, which in turn causes constriction of the vessels in the brain and causes them to have migraine headaches. So magnesium is specifically around the time of menstruation. You should take magnesium, and we will see that the intensity and the frequency of the migraine will diminish. This will continue up until menopause.
Okay.
If I could just comment, Omar,
Go ahead.
to Dr. Devasti's point, many women suffer from premenstrual syndrome, and B12, magnesium are two of the components of the, as Iso puts it, the gravy that we often recommend that many women take just for premenstrual syndrome.
All righty.
I have a question quickly.
Yeah.
For natural supplements to help with arthritis, big issue. What can we do?
Oh, the sky is the limit. The first thing would be the high dose of fish oil. I mean high dose. They will reduce the things that are causing the inflammation. They will reduce the interleukins that are the pro-inflammatory interleukins. So you will see that this works very well. All those things, the botanical medicine that are known to reduce inflammation would be helpful. You don't necessarily have to use all of them at the beginning, but a good amount of fish oil 3 times a day, but a very high dose 3 times a day would do a lot of what would help very much.
And for menopause symptoms too. That's another thing we get.
For what?
Menopause.
Menopausal symptoms.
Climacteric symptoms. Menopause symptoms.
Okay, that will be too long, but I'll briefly tell you something. During lifetime of women, at one point in time, they start to lose, or they don't produce enough, or they produce too much estrogen, and they're losing progesterone much faster than they lose estrogen. Iodine is known to help a lot. Why? Iodine renders the tissues that are sensitive to estrogen much less sensitive to estrogen, and iodine renders the tissues that are very sensitive to progesterone much less sensitive to progesterone. So you can give iodine. I give iodine for patients that have menopausal symptoms, fibrocystic disease. There's an article published in 1992 by Dr. Gann in Canada where he gave iodine. He was able to reduce or almost eliminate the fibrocystic disease in 70% of the patients. The same thing goes for ovarian cyst. The same thing goes for, so you can do this without necessarily pharmaceutical intervention, or you can combine to get the best of results. And this usually helps very much. I have been able to prevent patients to have, to take care of fibroid tumors, for instance, to shrink it, reduce it, or eliminate it, but not completely, because if you stop taking the natural product, you will see it again. So just to help them, if they don't want to have a hysterectomy, you can do that and kind of bridge the gap and allow them to go to menopause where they don't have to take anything.
All righty. We've run out of time, but I want to do one more question here. My daughter has bad eczema. It looks like she's has bruises all over her legs and her arms. What should I do?
This is an important question. If you're dealing with eczema, the eczema is not only in the skin. It's not the origin in the skin. You have to clean the intestine if you don't do that, you will not be able to get rid of the eczema. So the first thing would be spring cleaning in the skin by, one of the things I use would be oil of oregano to eliminate the bad microorganisms in the intestine. And then after that, reintroduce the good microorganism in the form of probiotics to recolonize the intestine and giving the patient a chance that the eczema will be dealt with aggressively and fully. So you combine the skin treatment with what you you should do in the intestine, and then you would get good results. But if you're only looking at eczema as a skin disease, a skin problem, you're missing the point. You have to clean the intestine.
Excellent, excellent. All righty, Dr. Devasty, thank you for coming on and
You're welcome.
Answering these questions. Our community is a community that natural medicine and holistic medicine is a part of. I think it's a part of our culture. And
if I didn't come, I would not get a chance to see Dr. Sprott, who I did a rotation in pediatrics in my 3rd year, and I have to say that I was very much impressed by him. And after I left the rotation, I decided I was going to stay in medical school, because before that I was so sick and tired of it. I thought I was going to leave and do something else. But he changed my mind, and I'm glad that I met him.
Oh boy, that goes back to our original reason for bringing all of the physicians together and doing this webinar is mentoring. And one of the reasons that we're all African-American males is because we want to mentor and show the young out there, the young Black boys and men as well, young men, that they can become a doctor. They can have, a career in medicine, and we want to mentor. We want to be an example that yes, it can happen, and that's a great story, because I must say Dr. Sprock is my idol as well. I remember coming through his ICU, and when I was doing my pulmonary fellowship, and boy, he's excellent. That's all I got to say. So
Thank you, Gerard. It was, I do recall having long talks with you because you're very bright, and we would have been at such a loss had you not continued.
All righty, thank you.
And so,
again,
some
thank
of
you
those
very
long
much
talks
for
are with
coming.
just many of us, because there are many of us who, whether we wanted to stay or not, we could not miss the opportunity of having some long talks and let us know when he thinks we're being serious or when we're not so serious. And sometimes the language was never so pleasant.
But it got us there.
It got us through.
Yes, and that's the thing. So I just thank each and every one of you for coming and putting this together. Let me end out with, I'd like to thank OBHealthy for allowing us to use their platform. Please go and check out their health benefits as far as weight loss. OBHealthy has a weight loss app as well as a website. We are here every second Saturday. Come to and join us and get your medical questions answered. That's 1 p.m. every second Saturday. You can join us. Please tell friends, family about it. The most important thing that I can say is do not change any aspect of your medical care until you consult your physician. This is a mainstay as far as we're concerned, and only your physician or healthcare provider knows exactly what's good for you as far as medical care is concerned. We are on YouTube now, and you can check out our past shows, or if you want to see this one again, it will be up on YouTube in a few days. That's OBHealthy YouTube. Please subscribe so we can continue to offer these forms on YouTube. Until next time, I'm going to say thank each and every one of you physicians for joining us today, and we look forward to seeing you next month. All I have to say after that is peace. We'll see you next month.
Bye, everyone.
All right.